Hello friends, today we are going to discuss about brain trauma foundation guidelines for traumatic brain injury. So regarding decompressive craniotomy, bifrontal decompressive craniotomy is not recommended to improve outcome as measured by the GOES score at 6 months post-injury in severe traumatic brain injury patient with diffuse axonal injury and with ICP elevation to values of more than 20 mmHg for more than 15 minutes within the 1 hour period that are the refractory to first tier therapies. However, this procedure has been demonstrated to reduce ICP and to minimize days in the ICU. Large frontotemporoparietal decompressive craniotomy is recommended over small frontotemporoparietal decompressive craniotomy for reduced mortality and improved neurological outcome in patients with severe traumatic brain injury. The committee is aware the result of rescue trial, which was released soon after completion of these guidelines. The result of this trial may affect this recommendation and may need to be considered by a treating physician. Then regarding prophylactic hypothermia, early short term, that is 48-hour prophylactic hypothermia is not recommended to improve outcome in patient with diffuse injury. Regarding hyperosmolar therapy, mannitol is effective for controlling raised ICP at the dose of 0.25 to 1 gram per kg. Arterial hypotension should be avoided. That is, systolic blood pressure should not be less than 90 minutes. Restrict mannitol use prior to ICP monitoring to patients with signs of transtentorial herniation or progressive neurological deterioration not contributable to the extracranial cause. And regarding CSF drainage, EVD system zeroed at midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than the intermittent use. Use of CSF drainage to lower ICP in patients with initial GCS score of less than 6 during the first 20 to 12 hours may be considered. Prolonged prophylactic hyperventilation with the PaCO2 of less than or equal to 25 mmHg is not recommended. Recommendation from the prior, then hyperventilation is recommended as temporary measure for reduction of elevated IC. Hyperventilation should be avoided during first 24 hours after injury when cerebral blood flow is reduced initially. If hyperventilation is used, then brain tissue oxygenation measurement are recommended to monitor oxygen delivery. Now, regarding anesthetic, analgesic, and sedative, administration of barbiturate to induce burst suppression measured by EEG as a prophylaxis against the development of intracranial hypertension is not recommended. High dose barbiturate administration is recommended to control elevated ICP, refractory to maximum standard medical and surgical treatment. Hemodynamic stability is essential before and during barbiturate therapy. Although propofol is recommended for control of ICP, it is not recommended for improving in mortality and 6-month outcome. So caution is required as high dose propofol can induce significant morbidity. The use of steroid is not recommended for improving outcome and reducing ICP. In patients with severe traumatic brain injury, high-dose methylprednisolone was associated with increased mortality and is contraindicated. Feeding patient to attain basal caloric placement is at least by 5th day and most by 7th day post-injury is recommended to decrease mortality. Transgastric jejunal feeding is recommended to reduce the incidence of ventilator-associated pneumonia. Early tracheostomy is recommended mechanical ventilation days when overall benefit is thought to outweigh the complication associated with such a procedure. The use of oral care is not recommended to reduce this ventilator associated pneumonia may cause uh, to reduce ventilator-associated pneumonia and may cause the increased risk of acute respiratory distress syndrome. So, antimicrobial impregnated catheter may be considered to prevent catheter-related infection during extraventricular drainage. Regarding deep vein thrombosis prophylaxis, LMWH and low-dose unfractionated heparin may be used in combination with mechanical thromboprophylaxis. However, there is increased risk of expansion of intracranial hemorrhage. In addition to compressive stocking, pharmacological prophylaxis may be considered if brain injury is stable and the benefit is considered to outweigh the risk of increased intracranial hemorrhage. There is insufficient evidence to support recommendation regarding preferred agent, dose, and timing of pharmacological prophylaxis for deep vein thrombosis. Regarding seizure prophylaxis, prophylactic use of phenytoin and valproate is not recommended. Phenytoin is recommended to decrease the incidence of early uh, post-traumatic seizure when overall benefit is thought to outweigh the complications associated with such a treatment. However, early post-traumatic seizure have not been associated with worsening. At present time, there is insufficient evidence to recommend levetiracetam compared to phenytoin regarding the efficacy in preventing early post-traumatic seizure and toxicity. So regarding intracranial pressure monitoring, management of severe traumatic brain injury patient using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. So ICP should be monitored in all salvageable patients with traumatic brain injury with GCS score of 3 to 8 and abnormal CT scan. Abnormal CT scan is one that reveal hematoma, contusion, swelling, herniation, and compressed basal system. ICP monitoring is indicated in patients with severe traumatic brain injury and normal CT scan if two or more of the following is present, like age more than 40 years, unilateral, bilateral, motor posturing, SBP less than 90. Now, regarding cerebral perfusion pressure monitoring, management of severe TBI patient using guideline-based recommendation for CPP monitoring is recommended to decrease 2-week mortality. Now, regarding advanced cerebral monitoring, jugular pulse monitoring of AV, arteriovenous oxygen content difference as a source of information for management decision and may be considered to reduce mortality and improve outcome at 3 to 6 months of injury. Regarding blood pressure target, maintain the systolic blood pressure of 90 to 100 for patient of 60 to 50 to 69-year old and more than 110 or above for patient between 15 to 49 years of age and more than 70 years of age to be considered to may be considered to decrease mortality and improve outcome. Treating ICP of more than 22 is recommended because values above this level is associated with increased mortality. The combination of ICP values, clinical and brain CT finding may be used to make decision. Now, regarding CPP, the recommended targeted CPP values for survival and favorable outcome is between 60 to 70. Whether 60 to 70 is minimum optimum CPP threshold is unclear and may depend upon the autoregulatory status of the patient. Avoid aggressive attempt to maintain CPP more than 70 with fluid and pressure may be considered because of the risk of acute respiratory failure. Jugular venous saturation of less than 50 may be threshold to avoid in order to reduce mortality and improve outcome. Thank you guys.